Welcome to Biomesight's Ask Me Anything episodes, hosted by Dr. Carly Polland, clinical lead at Biomesight. Biomesight is an AI-driven wellness analytics platform with a primary focus on the gut microbiome as a leading indicator of wellness. In these episodes, Dr. Carly will be answering your microbiome questions. Dr. Carly Polland specializes in the intersection of hormones, the microbiome, and the immune system in health and disease. She works primarily with individuals with autoimmune diseases and chronic digestive issues. While Dr. Carly is a doctor, she is not your doctor. These episodes are not intended to diagnose or treat medical conditions. Ask your doctor before making any changes to your health regimen. So our first question here is from a practitioner. So if the patient is severely inflamed and dealing with diarrhea, is it better to do a Biomesight test or a GIMap test? So I'm actually going to break down this question because there's an assumption here that may be incorrect. So the patient has, I'm guessing, GI inflammation and diarrhea. So the assumption that's being made is that a stool test is the best place to start. That is not necessarily true. When a patient has what we are assuming is severe GI inflammation with diarrhea, there are a lot of serious conditions that we need to rule out. So we need to be thinking about celiac disease. We need to be thinking about inflammatory bowel disease, such as Crohn's or ulcerative colitis. We need to be thinking about infectious pathogenic causes. So whether that's C. diff or salmonella or E. coli, some other infectious agent. We need to be thinking about pancreatic function and what's going on there. There are a myriad of conditions that we need to be considering. And so there may be blood testing, there may be endoscopies, there may be colonoscopies, there may be a lot of other things we need to do before doing a Biomesight test. So the second part of this question, I guess, is if you are wanting to do a stool sample to look at the microbiome, should you be considering a 16S rRNA test or a PCR test? So that depends on what you're looking for. So I like to use PCR when I am assessing for specific pathogenic strains of microbes. PCR has the ability to be accurate down to the strain level, but it's not going to be able to report on a wide variety of things. It's going to be limited in the number of microbes it will report on. Whereas 16S rRNA sequencing is going to give you the entire bacterial ecology. So both have a time and a place, and sometimes I do both at the same time. Now, when it comes to PCR testing, the kind of third part of this question, would I do a GIMap? Now, my personal clinical opinion is no, I would never use a GIMap test. I used to use these extensively until I started seeing some very irregular reports on things that didn't make sense. And I looked into it. There are studies that are showing that the GIMap, particularly for the pathogens and H. pylori, are not accurate. I've seen anecdotal evidence from split sample testing from various practitioners where they're getting completely different results. So I no longer use the GIMap test in my practice. I do not find it accurate or reliable. So if I were going to go with a PCR test, I might actually use one through a conventional laboratory if I'm just concerned about pathogenic bacteria. The next question is, do you see any particular trends on the Biomesight test with people that have chronic fatigue syndrome? Yes. Typically, I do see low butyrate producers, and I know some of the research has backed that up. The other big thing, which is outside of the Biomesight test that I see with the microbiome of people with chronic fatigue syndrome, is small intestine bacterial overgrowth. The next question is about LPS in long COVID and its connection to clot. So this individual is wanting to know if by healing your gut barrier, could you possibly reduce the risk of clots? Yes and no. So yes, LPS can trigger the coagulation cascade that would then lead to a clot. However, in the context of COVID, there are various mechanisms, as I understand, that can trigger clotting. So by reducing LPS's role in forming the clots, is that enough to actually completely resolve clots from forming? I don't know. But definitely, if there are higher levels of LPS present, that is going to make clotting worse. So it's always going to be a good idea to reduce the systemic absorption of LPS, reduce the amount of LPS producers. So there we need to think about if there is more LPS in the bloodstream, there's a couple of mechanisms behind which that can happen. So one is if the gut barrier is impaired, you're going to be absorbing a lot of things from your gut. One of those things is going to be LPS, and COVID can cause dysfunctional gut barrier. The other thing is if you have high amounts of bacteria in your intestines, whether it's the small intestine or large intestine, that are producing LPS, you're going to have higher levels of LPS in the blood, whether or not the barrier is dysfunctional. So you want to be thinking about targeting LPS producers as well as the gut barrier in your treatment in order to reduce the systemic levels of LPS. I would say the biggest concern for LPS producers in this context would be from small intestine bacterial overgrowth, because that is also going to be causing impaired barrier dysfunction, and COVID can trigger the small intestine bacterial overgrowth. So it's all kind of muddled together there. So the next question is about diet and non-tuberculosis mycobacterium. I cannot speak to that, not my area of expertise. But the second part of this question is obviously a part of treating mycobacterium is you're going to be on several different antibiotics. So maybe what should you be eating to support your microbiome while you're on an intensive antibiotic protocol? So I'm not aware of any research that has looked at this specifically, but based on my understanding of the microbiome, there's a couple of things I'd be thinking about. So one would be possibly reducing animal sources of fat and protein, as those can feed more inflammatory bacteria. So there is a possibility that eating too much of that during an antibiotic course, you might skew your microbiome towards proteobacteria, towards the hydrogen sulfide producers. And so then you'd want to be thinking about supporting your butyrate producers and your keystone species like lactobacillus and bifidobacterium. So making sure you're eating a wide variety of different plants, looking at prebiotic content of your food, looking at polyphenol content of your foods, general fiber content as well. And the variety is also going to be important. One of the biggest things antibiotics are going to do is reduce diversity, and to support diversity, variety of plant-based foods is going to be very helpful there. The next question is about PANS/PANDAS and whether or not SIBO or other gut issues are causing that. So no. So my understanding of where the research is to date is that strep, and now we're looking at COVID as being the initial infectious triggers. So with those triggers, what's happening is cross-reactivity. So the immune system, because of those infections, is getting confused, and it's now attacking the basal ganglia in the brain. And that is what is causing all the nervous system issues. So with that, we don't have evidence yet that SIBO or other microbiome imbalances are what are initially triggering that. But definitely with the nervous system imbalances, you may be more at risk of developing SIBO, in which case the inflammation from that, of course, is going to further drive this autoimmune attack on the brain. So there is a connection there, but are these issues directly causing PANS? No, I don't think so, but we still need a lot of research in this area. The second part of this question is asking about strep titers being high when the throat culture is negative. So strep titers are testing antibodies. Antibodies can persist for up to 1 year after the initial infection. So that is why you can have positive antibodies, but negative culture. So the next question is about using an antifungal in the treatment of autism. I cannot comment on this. This is not my area of expertise. The next question is about supporting your microbiome and gut health after you have had your colon removed. So as far as I understand, this is not an area that the research has looked at extensively. So I do know a couple things from the research. So definitely people who have had their colons removed, they are more at risk of bacterial and fungal overgrowth in their small intestine. So supporting your small intestine ecosystem, which should be not a lot of bacteria, is probably going to be a big driver of digestive symptoms after this. In terms of, in this case, this individual has 10 centimeters of their colon left, how to support a healthy ecosystem in that bit of colon. Again, we don't have the research there. So I think in terms of symptoms, probably addressing the small intestine microbiome is going to be the most important there. So the next question here is about the connection between the microbiome and a cellular process called the ubiquitin proteasome pathway. So this pathway is important for essentially cleaning up the inside of our cells, cleaning up proteins that have been misfolded and are non-functional. So essentially, the research does not have a solid answer for you here. It looks like this may be an area where the research is looking into, but there are no definitive answers here. But based on some basic physiology, I would expect that a couple of key features of the microbiome are going to influence this pathway. Now, the question is, will it influence just this pathway in gut cells, or will the microbiome also have an influence on this pathway throughout your entire body? I don't know. Probably it's going to be most important for the gut cells, and it will have a mild influence on this pathway throughout the rest of the cells in your body. So definitely having high levels of butyrate production from your microbiome in general is going to support healthy immune response, healthy metabolic responses, and all of that. Making sure that your LPS levels are in check, particularly from proteobacteria, as LPS is going to be inflammatory. And then also the other thing here is making sure you have healthy levels of lactobacillus and bifidobacterium. So we do know from the research that polyphenols, which are antioxidants coming from the pigmentation in our plant-based foods, so thinking about dark berries, polyphenols are where those berries get their color. That is very important to a healthy ubiquitin proteasome pathway. In order for our bodies to best utilize polyphenols, most of them do need to be converted and activated by our microbiome, and lactobacillus and bifidobacterium are going to be main players in activating polyphenols. So I would guess having healthy levels of bifidobacterium and lactobacillus are going to support a healthy ubiquitin proteasome pathway, but you're also going to need to make sure that you are consuming enough polyphenols for that to be helpful. So the next question is about amino acids, particularly from meat, are converted to short-chain fatty acids. Now, my understanding of the research is they're not necessarily looking at what is the source of the amino acid. So amino acids can come from plant and animal sources, but they do look at how different amino acids can be utilized by different gut bacteria to produce short-chain fatty acids. Now, I know one study suggested that the amino acid contribution to short-chain fatty acids is relatively small, only like 5% of the short-chain fatty acid production. But definitely different amino acids can contribute to the primary short-chain fatty acids. So we see that glycine, threonine, glutamate, lysine, ornithine, and aspartate can all be used to produce acetate by certain bacteria. Threonine, glutamate, and lysine can be used to make butyrate, and propionate is mainly going to come from threonine in terms of amino acids. So again, carbohydrates are going to be the best source of raw material for the microbiome to produce short-chain fatty acids, but amino acids from protein can also be used a little bit to make the different short-chain fatty acids. The next question is asking about a broad spectrum prebiotic for somebody who is on a low-carb diet for insulin resistance. So the answer is no. I never would recommend a broad spectrum prebiotic for any condition. It is all going to come down to that individual's microbiome. And individuals who have insulin resistance and are on a low carb diet, their microbiomes can look completely different. So you're going to have to take a look at the microbiome and based on that, decide which prebiotic is the best. Now, depending on how they're going about their diet, definitely with the low carb diet, I have seen some people do very well with, say, their butyrate producers, even though they're not getting a lot of fiber or a lot of carbs. But if they are heavily relying on animal fat and animal protein, I do see a lot of hydrogen sulfide producers and a lot of inflammation coming from the microbiome. So yes, definitely the microbiome may need some support from a prebiotic, but you're going to have to individualize it. The next question is, how can you observe changes in ATP production from a stool sample? I don't think you can. I'm not quite sure exactly what this question is asking, since ATP production is an intracellular process. So I don't know if we're talking about in gut cells, if we're talking about some other organ, all the cells in your body. So I can't really answer that question. And essentially, I think probably the answer is no. You're not going to be able to look at a Biomesight test and derive any information about ATP production in any sort of cell in the body. Likewise, the next question is asking about mitochondrial function and what you can tell about that from a stool sample. Again, mitochondrial function, that's an intercellular process. It's going to vary depending on what type of cell it is. So my answer would be no, we cannot say anything definitive about mitochondrial function of any cell based on information from a stool sample. Now, with that said, based on some basic physiology, making sure that inflammation is in check, that's going to be more supportive of healthier mitochondrial function, and the microbiome can impact inflammation. It can impact the immune system. So indirectly, making sure proteobacteria are in check, making sure butyrate production is solid, those may be indirectly helpful for mitochondrial function, but we can't actually say, oh, your proteobacteria is high, so your mitochondrial function must be impaired based on a stool sample. The next question is about anti-LPS antibodies. So there is one company that I'm aware of that has anti-LPS antibodies commercially available. This is not a standardized diagnostic test, and I do not use it in clinical practice because antibodies, for the most part, depends on which one, are telling us that, yes, your body has been exposed to this thing. So, of course, we all have LPS. That is a natural part of the microbiome. It's not all bad. We need some LPS to actually educate our immune system. So we are all going to have anti-LPS antibodies. And per my understanding of the research, we do not actually have extensive data to support saying a certain level of anti-LPS antibodies mean anything clinically. So this particular company, they are claiming that certain levels of anti-LPS antibodies indicate leaky gut, essentially, so an impaired intestinal barrier. Again, I have not seen super solid research to back that up, so I do not use this in clinical practice. And definitely there are better ways to test for leaky gut than anti-LPS antibodies. So the next question is about parasites and health. Parasites and their impact on health, particularly in the context of chronic fatigue syndrome or long COVID. So I can't speak to in the context of chronic fatigue syndrome or long COVID. I would say that we don't actually know. This is a very, actually quite controversial area. And I know parasites are a very hot topic. Mostly I'm seeing this kind of in the online spheres, whether that's social media. I think it's honestly being driven by a lot of supplement companies, and the research is not fully there yet. So I expect the research to be digging into this topic in detail in the next 5 to 10 years with the advanced sequencing technology that we have now available. But to date, there is no consensus on the research. It's going to depend on diet, hygiene practices, medications, where you are physically located, and the clinical impacts are going to depend on, is this an invasive species to your microbiome, or is it part of the ecology? Did it colonize you when you were quite young? So it can be difficult to determine on testing whether it's invasion or colonization, and that is going to dictate the clinical impact it has on you. So the other thing here is what we're seeing is it may be the symptoms of clinical impact is actually more about how the bacteria and the parasite are reacting, how they are interacting. And this strain may be very important for clinical impact as well. So with Blastocystis hominis, certain strains are considered virulent, but others actually may be fine and they may be a healthy part of your ecosystem in your gut. So I think we need a lot more research to fully investigate this, and parasites may actually not be problematic. And if you do have a parasite, the problem may be more how your bacteria are interacting with the parasite. So I know it's not the answer people want. And I know a lot of practitioners, their opinion is that if there's testing positive for a parasite, they believe in treating it. But like I said, we need a lot more research to give really good answers about this. So the next question is about why probiotics may make symptoms worse. There's a variety of answers here. So I first want to speak to using probiotics. So in my clinical experience, probiotics have a somewhat minimal impact on modulating the resident microbiome. They have more of an impact on the host, on you. So they may have more of an impact on your immune system. But if your end goal is to change your resident microbiome, my opinion and my clinical experience support that diet, prebiotics, and herbs are going to be better tools to do that. So, first of all, probiotic may not be jiving with your microbiome, but I most commonly see probiotics making symptoms worse when a person has small intestine bacterial overgrowth. And we have to also look at the specific probiotic because it may not actually be the bacteria in the probiotic that are the problem. It may be that probiotic formulation has the addition of a prebiotic, which is the second part of this question. Why do some people not tolerate prebiotics? So again, the most common scenario is when a person has small intestine bacterial overgrowth, prebiotics can be absolutely terrible in that case. So prebiotics may also cause some issues if it's not the right prebiotic for your microbiome. So some prebiotics are, I would say, very generous and they feed a wide range of bacteria. So if you have a specific overgrowth, like a proteobacteria overgrowth, certain prebiotics could potentially feed that overgrowth. So that's another possibility for why prebiotics would not be tolerated. The other thing to think about with prebiotics is they're gut bacteria food. So when bacteria eat them, they are going to ferment. Fermentation produces gas. So some people don't like to use prebiotics because of that gas production. There are ways to mitigate some of these normal, natural side effects, and that is by starting with playing with the dose. So some people need to actually start with a sprinkle of a prebiotic for a couple of days and gradually build up. If you start taking an entire scoop of prebiotic right out of the gate, yeah, you're going to get a ton of gas. It's going to be painful. It's going to be uncomfortable. So how you take and how you introduce the prebiotic may be another aspect of tolerating the prebiotic. The next question is about a probiotic to help with idiopathic kidney disease. Well, the answer, I do not know of any because in this case, it's idiopathic kidney disease. We would really need to know what type of kidney disease to be able to pinpoint a probiotic in the research. But based on my clinical experience, there's going to be a lot more effective treatments for various kidney diseases than a probiotic. That would be lower on my list of things to think about for various types of kidney disease. The next question is why a low residue diet and juicing are the most helpful for symptoms. So typically with that, my first thought would be about the small intestine microbiome and if there is an issue there. In my clinical experience, when individuals have a lot of issues around food, it's usually due to the small intestine microbiome and fermentation of the food happening in the small intestine. There definitely are other considerations there, but that would be the first place I would start. The next question is asking why we have a low amount of doctors in the US that are studying the microbiome. So that's actually not true. There are a lot of doctors with PhDs or MDs that are studying the microbiome, but those individuals are not in clinical practice. So yes, there is absolutely tons of research being done on the microbiome, but it is very rare, I would say, for clinicians to be applying this research in clinical practice. And that is because of standards of care. So especially in conventional medicine, the typical way it works is they wait for the research to be tried and true before it affects what they do in practice. That process will usually take about 20 years. So essentially, standards of care in conventional medicine are about 20 years behind the research. And you are more likely to find a doctor who's practicing integrative medicine who is willing to go outside of standards of care and start applying the research. But the reality is, while the research has exponentially exploded in the last 5 years, there's still so much to learn here. And so there's going to be a lot of resistance from doctors to actually start applying the research we have. They want to wait for the full story before they will start, quote unquote, treating this. So that's what's going on there. So the next question is about the microbiome, IBS, and histamine intolerance. So there's a lot within this question. So first, let's talk about the microbiome and IBS. So yes, the microbiome may be playing a primary role in IBS symptoms. Now, the first thing to understand is IBS, it is a syndrome. It is not an actual definitive diagnosis. So syndromes are basically a collection of symptoms that we don't know why it's going on, so we've just put this label on it. It doesn't actually explain anything about what is going on. So the research shows that possibly 60 to 80% of people who have been diagnosed with IBS actually have a small intestine bacterial overgrowth. My clinical experience supports this. So the Biomesight test is not going to be able to tell you any information about small intestine bacterial overgrowth. However, digestive symptoms that have been categorized as IBS may also be driven by imbalances in the large intestine microbiome, in which case Biomesight could tell you about those imbalances. So in my clinical experience, I have seen high proteobacteria driving some of the digestive symptoms, particularly high hydrogen sulfide producing bacteria that are within proteobacteria. And then sometimes low bifidobacterium and low lactobacillus and low butyrate producers are also driving digestive symptoms. So the next part of this is about histamine intolerance and the microbiome. So histamine intolerance, that is a very complex topic, one that we can't really get fully into. But yes, the microbiome may be playing a role. Now, with histamine intolerance, there's a couple things that may be going on. So one is that your gut may not be able to handle histamine coming from your food. So this is typically because of a genetic reason, a pharmaceutical reason, other reason, your gut lining is not producing the enzyme DAO that breaks down histamine. So this is coming from your body. It's not coming from your gut bacteria. So then, in which case, you would absorb more histamine from your food than somebody who would have this enzyme. It's also possible that your microbiome is producing too much histamine from, say, histidine, in which case the Biomesight test does give you a breakdown of those histamine-producing bacteria and kind of gives you an idea of your level compared to other Biomesight users. So you can take a look at that. And my clinical experience with histamine issues, that it's much more complicated than just one thing or one microbiome imbalance. The next question within this is about FODMAPs and the Biomesight test. So FODMAPs are going to be fermented by the majority of bacteria in your gut. So there is no specific reporting on that. And so when those FODMAPs are fermented, that's going to produce gas, which may lead to digestive symptoms. So yes, Biomesight results and addressing those results may be able to help with various digestive symptoms that are called IBS, as well as any issues around histamine. However, in my experience, histamine issues are more complicated than just a simple microbiome imbalance. So other components to histamine intolerance are, once histamine is absorbed into your blood, does your body have the ability to fully break down that histamine efficiently, in which case there may be some genetic components there, or there could be some nutrient deficiencies playing a role there. We also have to think about, when it comes to histamine issues, what is your immune system doing? is it the source of histamine? Is it releasing too much histamine? So this is called mast cell activation syndrome. And with that, you have to pinpoint what is irritating these mast cells and causing them to release too much histamine into the system. So there definitely can be an overlap between mast cell activation syndrome and histamine intolerance, where your mast cells are just dumping histamine at any opportunity, and then you genetically are not able to handle that histamine and get rid of it efficiently. So then you're going to have some pretty significant symptoms there. So it's a very complex issue, and there's a lot more than just the microbiome. And for both these issues around histamine and IBS, I would definitely also be looking at the small intestine microbiome as well. So the next question is asking about how an imbalance in gut bacteria could cause motility issues in the gut. So it's much more complicated than that. And there's a complex interplay between the motility in the gut and the microbiome. So it's kind of chicken or the egg sometimes. Was it the microbiome issue that triggered the motility issue, or did the motility issue then lead to the microbiome issue? So let's get into a couple examples here. So one somewhat common motility issue, which is mostly going to be targeted to the small intestine, is going to happen after food poisoning. So food poisoning is going to trigger your immune system to start attacking your small intestine, particularly the parts that communicate about flow, about motility. And so this leads to dysmotility in the small intestine, which will eventually lead to an overgrowth of bacteria in your small intestine bacterial overgrowth, SIBO. So we had a microbiome imbalance, the food poisoning, triggering a motility issue that then triggers another microbiome imbalance. In terms of large intestine motility, definitely the metabolites from bacteria are going to influence motility. So in particular, if you have too much methane production, that can slow things down. And we definitely need healthy levels of butyrate to maintain proper motility as well. But directly speaking to your question, I have not seen any research that demonstrates that a microbiome imbalance is the direct and primary cause of specifically gastroparesis, which is a motility disorder in the stomach. So we do need more research here and to tease out exactly what's going on. We do see in the research that with gastroparesis, there is a higher prevalence of small intestine bacterial overgrowth. But did the small intestine bacterial overgrowth cause the gastroparesis? We don't have the answer to that. Probably not. There are a lot of other conditions that are affecting the nervous system that can cause these issues. But obviously, microbial metabolites can impact the nervous system. If there is an autoimmune attack on the nervous system driving the motility disorders, the microbiome can influence that inflammation and that immune activity that's leading to the attack. So it's all interconnected, but we don't have a clear-cut answer on what's driving what. So could overgrowth of Bacteroides or E. coli, I'm assuming in the large intestine, cause gastroparesis? I'm going to say no to that one. I don't know that there is research that specifically investigated that, but based on my understanding of the microbiome and physiology, I think it's highly unlikely that that would cause gastroparesis. Head on over to biomesight.com to purchase your stool test kit to discover your microbiome. Practitioners can register for a free account to get access to our gut microbiome analysis platform that supports FASTQ uploads from multiple labs.